Welcome to the ANEW Insight Podcast, empowering and inspiring your journey to optimal health. Hosted by Dr. Supatra Tovar, clinical psychologist, registered dietitian, fitness expert, and author of Deprogrammed Diet Culture. Rethink your relationship with food, heal your mind, and live a diet-free life. And Chantal Donnelly, physical therapist and author of Settled, How to Find Calm in a Stress-Inducing World. Here at City Club Los Angeles, we follow our guests' journey to optimal health, providing you with the keys to unlock your own wellness path. Tune in and evolve with us. We're really excited to have Dr. Richard LaBrie here with us today, and I'm going to read you a little bit about Dr. LaBrie, and then we're going to go into our questions for him. Does that sound good?
Mm-hmm.
Okay. So Dr. Richard LaBrie is a clinical psychologist in Pasadena, California. He primarily works in private practice, providing psychotherapy to a variety of clients regarding trauma, depression, anxiety, identity exploration, self-esteem, grief and loss, creative issues, and life transitions. He was also my postdoc supervisor and has personally been responsible for creating the psychologist you see here today. He's also worked with Salis Solutions as a senior advisor in individual trauma, mass trauma, and behavioral and security issues for the FAA and the Department of Homeland Security. So welcome to City Club. We're in downtown Los Angeles, the beautiful, beautiful City Club. Dr. LaBrie.
Yes.
You have an extensive background in the entertainment industry. You used to be a writer, a director, and a film editor. Can you tell us a little bit about how you made your transition away from the entertainment industry and towards clinical psychology? What was your inspiration?
Well, fear, age, anxiety, and recognizing that sitting in an editing room or working in that field gives you a little bit of training about how to sit with people who have anxiety and depression and a high level of focus and stress. So now I was in the industry for about 35 years. And as I was approaching age 50, I could see that the industry was changing. And I was mostly working as an editor then. And I could tell that it wasn't going to be, for me, satisfying or reliable to stay in it. Even though I was doing very good work, and even when I went to grad school, I kind of hit a pinnacle of the kind of work I was doing and worked on really one of the best shows in sketch comedy, because I had my career had veered me over into sketch comedy for much of my editing career, and I ended up working on the show called Key and Peele for 4 of the 5 seasons, and it was amazing. And people asked me, why would you leave if you're working with these incredible people? And I don't think the field is reliable enough for me to think that that would have repeated itself. Mm. And I wanted something that was a bit deeper and matched who I was. So I, at the old age of 49, went to graduate school and got my doctorate in 2015, got licensed in 2016, and I've been practicing since before then. The minute I could practice, I started practicing.
Mm-hmm. So. Well, what would inspired you to go into psychology?
Really good therapy that I was in. I had an excellent therapist for a long time. He's now passed away. His name was Larry Lewis. And most of the people I know in the field at one time or another are in therapy because it's good for you and it helps us with the stresses of this job. But I watched how I worked and how my therapist worked in the room, and I became more and more interested. And I've always had an interest in philosophy, sociology, and how kind of the human experience fits together over time, as we develop and age, and it fit. And there is something about being an editor in film, television, that allows you to feel what's happening in the room when you're screening things and you're working on projects. And there's a lot of nonverbal communication, and the transition was relatively smooth.
Wow, that's a really interesting comparison. I love the fact that at 49 you made such a big shift. He must have been a really incredible therapist to want to follow in his footsteps.
Yeah, when I first started exploring it, he, I think, tried to use a paradoxical intervention, which would mean say the opposite. So he said, why do that? Just make movies that help people. And I was so sick of, I had been a director for a couple of years. I'd made a few films, and I'd gotten out of that in 1996. And just the thought of that made me curdle.
Mm-hmm.
A few weeks later, I went in and started speaking more about it. And he didn't argue at that point. He realized I was committed. And then he helped guide me towards, a pathway that worked for me in terms of school kind of program. So, yeah, and it's been a great transition. I wish I'd done it earlier.
Because film editing can be really taxing, physically, mentally, emotionally.
Yeah, I like that craft. I really do. I really respect it. It was more about the hours being put in, the expectations, and some of the dynamics I could not count on because I was working as a freelancer. So I really wouldn't know what the dynamics of that production company or that show would be before I got in. I would try to do as much intel gathering as I could on the showrunners or the producers. And I was mostly lucky. But I couldn't see myself in my 60s doing that. I just couldn't. Ironically, I work almost the same hours now, but at least I'm in control of it. And so I don't have to work a long day because somebody forgot the bagels, so the lead actor or actress threw a fit, and then they shut down the cameras, and then the editors got the film late, and then we had to stay up and get it out for the air date. And I don't have to do that.
Yeah.
I just choose to take another client because I want to.
Yeah. Is that why you chose private practice as opposed to there's a whole bunch of routes that people can take? They can work for hospitals, organizations. What made you choose private practice?
Yeah, I think I knew that I could manage myself and that I could embrace the creativity and the freedom of a private practice, as well as manage the risks. And so I could tell I was built for it. Maybe not the best institutional player, although I'll appear to be. But inside my head, I'm not. I just kind of went out of there. So I put on that dress shirt for all my practicum and hospital training and all of that. And then as soon as I had my practice, I pretty much dressed like a 7th grade gym teacher in therapy. So, I put this jacket on for you guys.
You're fancy today.
Yeah,
You're all dressed
right?
up for us.
See that? So, and it's been a great transition.
Well, tell us about your specialties. I mean, you treat a variety of different types of clients. I know that there's clients that you treat for trauma, for DID, dissociative identity disorder. You treat people for grief and loss. Give us an idea of how you decided to specialize and why.
Well, first I had really good training, both in the classroom and in my training sites. I just lucked out. I had great supervisors and great professors. And so I got a wide range of training, not just learning the DSM and what the disorders were, but really learning, what we would call the precursors or the etiology of each disorder and what's behind a symptom that comes up in a person. And so I would be in practicum and say there would be people coming into the clinic and they would say, I only want to see a female therapist. They would often be a female themselves and they had maybe sexual abuse or physical abuse in their past. I don't want to talk to a man. They didn't have any choice because I had openings, so the supervisor would assign them to me. And I found that it worked. They wanted to stay. Somehow I could create, a safe space and an open ear. And so I kind of knew I could be comfortable with that. And I was also comfortable working with teens at the time. I don't now, but I saw a lot of teens through some school districts. And And regarding trauma and dissociation often goes with trauma in one way or another. And I had some training in dissociative identity disorder, and a client came in. I was originally seeing their son. The client fired me after 2 sessions with the son, which was funny. We joked about it later. But as I did follow-ups with the family to see how they were doing, the mother started expressing certain things about what she was going through. And then I ended up seeing the mother. And that was my first case of dissociative identity disorder. Luckily, I'd had some training, and I seem to have an affinity for it. I understand how it works. She felt comfortable. And then I've had a number of other clients come through with that disorder. It's very difficult work. Any complex trauma is very difficult work. So I don't fill my practice with complex trauma cases. I tend to have a variety of professionals and some younger adults and people with trauma, people going through life changes, people who will just call because they're not feeling right. They're having somatic complaints, shoulder pains or other things, and it's really coming from other areas of their life. Sometimes we find out it's not medical and it's emotional. And I work with people in the creative industry, so I work with a number of people in post-production, editors and actors, actresses, a writer or two, because I understand the language of the industry and the creative pressures. And they will often say to me that they sometimes have had to spend so much time explaining why someone in the entertainment field works 12 to 14 or 16 hours a day, or how they handle being freelance. And so my clients have appreciated that I've been there, so they don't have to explain that. And we have a common language. So that's kind of my practice right now. It changes over time. So.
It sounds like there's a lot to take on. I love that when you were in the hospital, you had women saying that they didn't want to talk to a man, and yet you were able to create such a safe space. That must be a real superpower for you. But creating that safe space can be really taxing on the person creating that nice environment.
Yeah.
So how do you go about taking care of yourself?
My family would say poorly.
They're not here, so you can lie.
right. Maybe they'll listen. Well, I do exercise most days of the week. I have a routine I've been using since high school, so that works for me. I am a musician, and I got away from playing a bit, but I built, during COVID, my way of coping was I built a small recording studio, and I put together everything that I wanted for the rest of my life in there. So I'm starting to record again, and I make sure I get enough sleep. And I have changed my practice in terms of how many people I take in to the practice. At first, I would say yes to everything. As you know, Supatra, you want to build your practice. I finally reached the point where I could start saying no. And it was tough during COVID because we really wanted to serve more people, and we had an onslaught, and doing pro bono work on the side, there were so many people suffering. But now it's starting to stabilize. And so, I don't know, I do my best. Trauma works hard. I internalize sometimes my clients. The oddest thing that happens is sometimes I will have what I call my clients' dreams. I have my clients' nightmares. So I'm experiencing something in the dream, and it's me, but it's their story. And it's sometimes scary. It's a scary story they told me. And it morphs, and those are, the first time that happened was really strange for me. But, I'm used to it. Now I can consult with other people when they experience it. So.
Right. Do you find that if you're not exercising and doing your creative work with music and maybe taking on too many clients, that's when those nightmares can happen?
Sometimes, or they can surprise me. Yeah.
happen either way.
Yeah, yeah. But because I'm not really taking any new clients right now, it usually isn't sneaking up, although I had one the other week. So it's hard to predict.
So that's your subconscious is very empathic.
Yeah, I think there's a concept in psychoanalytic psychodynamic therapy called, we know what projection is, most of us, and we project our own feelings onto someone else. And projective identification is when the other person actually receives the projection and starts acting that way for real. I think therapists are susceptible to that and should be. So if a client projects something onto me, to the extent that I'm able to feel it, is really good for the therapy, because then I can kind of analyze what I'm feeling through their projection. When you're working with trauma, you kind of have to have some internal boundaries with that, because you can get really pulled into the despair. But you want to let yourself get pulled into some of it. But if it goes a little too far, and it has for me over, the past several years ago, I had some very, very difficult cases, and I didn't quite know how to do that. And a wonderful psychologist named Bobby Carlson, who's passed away now, I was consulting with her about a case, and she said, it sounds like you need to develop some internal boundaries. And I didn't know what she meant. I said, that's such an abstract term. Mm-hmm. Like, what,
Internal boundaries, yeah. It sounds like a lot of us need something similar, even though we're not treating people with trauma, but with the media nowadays,
sure.
And taking in all of that information that at a time we didn't have information about everything that was going on in the world. Yeah. Is that the same kind of thing where we are feeling too much and taking in too much, and maybe we need more internal boundaries?
Yeah, I think with things like the news, you can it can be easier because you can mechanically do that. You can say, okay, I'm only going to read this many headlines or watch this many news shows. With the clients, it's a little more abstract, and it's kind of like being able to turn off. But most of us think a little bit about our more puzzling cases outside of the therapy session, and so we just have to be careful how much we do that, and retell the narrative of the client to ourselves, or how far we let it in. Maybe we can be analytical about it, but not let the emotion in too much. I don't think there's a rule book for it. It's you got to figure it out yourself. So.
Right.
When you're treating clients, give us a picture of what you're doing. What goes on in a session with you? How are you taking them towards healing?
Well, in our clinical training, it's so clinical, right? It's so rote. And I have a big problem with how psychotherapy is blended with medicine in terms of its expectations. I think we're part of healthcare, but we are not medicine. And so the treatment is based on the client's style and my ability to morph a little bit towards the client's style. I don't do a formal intake because I have found that if I give a form with questions on it to the clients, they feel a little bit alienated. They'll often not finish it if it's homework that has been sent before the first session, or if they're sitting with me, they feel disconnected from me. So I don't take notes. I keep my eyes on the client, and they open up right away, and it's just has something to do with the style. As for picking a certain method that I work with, and I mainly work relationally, psychodynamically, which means working with what I'm hearing and seeing in the nonverbals and the unconscious, but also cognitively and behaviorally and somatically based on what the client needs. So if a client is coming from a highly cognitive place, and that's the only way they can communicate, then I'll stick with that. But if they're so cognitive that there's other parts of their experience that might be missing and I see them as important, I'll try to invite them to look at, say, their body reactions, or, I heard you say this, and I'll do a kind of an interpretation that shaves a little bit of the onion off to make them think about something that might be less conscious. But if they don't respond to that, I'll go back to cognitive. And then there's the opposite. Like somebody might come in, they're just experiencing the world in a highly emotional way. So we'll work in that. And I find that once I find the language, then we can move into a more holistic approach. So I don't know if that sounds too abstract or not, but
No, but it doesn't, and it takes a lot of observational skills, which sort of going back to when you were talking about working in the entertainment industry, it's that lens from behind the camera that you've developed that helps you in that setting, like you were saying. It's pretty cool.
yeah, in the editing room, usually the people are behind me, and you can feel, especially I worked in comedy a lot, and you can, I wouldn't even have to wait for them to say, I would like know to stop it and we're going to adjust that joke. You can just feel it. And so that's why nonverbals are really important to me too. I mean, there are times in sessions where I'll stop and we'll just look at each other and I'll say, what's happening here? And then we kind of like have to deconstruct it, you know. There's a great book called Attachment in Psychotherapy by David, is it Wallen? Anyway, he talks a lot about that. Like what's happening from an attachment point of view and a nonverbal point of view and in the feeling in the room. So I use a lot of that, the term, what's in the field between us, what's in the field in the room, and taking risks and bringing things into the field that aren't there, which can backfire, or working with what's in the field and calling it out, or staying in the field.
And I think a lot of people are not aware of that field. Most of us are living from the neck up. And so we don't notice when things are happening in our body or the energy changes between someone, or we speak in a way where our tone changes, and it says a lot.
Yeah.
So it does take a really great therapist to be aware of all of those little nuances.
Yeah. It also makes the job fun and creative.
Yeah.
You know, when you're not having nightmares and weeping into the pillow based on something you never experienced.
Thank you for joining us. Tune in next week for the second half of this thought-provoking and insightful interview with Dr. Richard LaBrie. Thanks for tuning into the ANEW Insight Podcast. Please remember, the content shared on this podcast is for entertainment purposes only and does not constitute medical advice. You can find us anywhere podcasts are streaming, on YouTube at my.anew.insight and at anew-insight.com under the ANEW Insight Podcast tab. Follow us on our socials at my.anew.insight on Facebook, Instagram, TikTok, and Threads for more updates. Tune in next time and evolve with us.